Hello, and welcome to the Complex Care Journal Club podcast. My name is Christy Malik, and I'm a pediatrician at Children's Hospital Colorado, and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I am delighted to have Dr. Katie Chiotos and Dr. Jeff Gerber from Children's Hospital of Philadelphia and the University of Pennsylvania School of Medicine joining me today. They are the lead authors of the article Off-Target Impact of Clinicianal Feedback Reports on Antibiotic Use in Children with Medical Complexity Hospitalized with Community-Acquired Pneumonia. And I just want to thank them for being here.
Yeah, thanks so much for having us.
It's a pleasure to be here.
To start, I want to give a little context to our listeners about this paper. So this paper is a secondary or post-hoc analysis done after an initial study. This original study was an intervention using clinician feedback reports to general hospitalists on the adherence to community-acquired pneumonia guidelines. And specifically, you were focusing on the choice of antibiotic as well as the duration of antibiotic. This initial study was quasi-experimental with a pre-post analysis at two different sites, a quaternary children's hospital and a community hospital. And then the paper we're talking about today, this was a study looking at children who were excluded from that initial intervention, children with medical complexity. And they were excluded because they're not part of the national guidelines, but you also recognize how studying this population could affect the confidence of your primary analysis. And so I just want to talk a little bit about the methods that you use to study children with medical complexity, but even more so, why did you study them? Because as a complex care pediatrician, I find this population really important to study, but we often don't see studies like this.
Yeah, thank you for setting this up so nicely. You're exactly right. In our initial study, which really focused on previously healthy kids and utilized these feedback reports that we generated exclusively really from EHR data, structured EHR elements. And for that reason, we really limited that to appropriateness determinations that we could adjudicate solely based on electronic health record data. And so some of the nuances of kids with medical complexity are very hard, as you probably know from your work, to pull out through EHR data. And exactly as you said, we really wanted the clinicians who were receiving these report cards to feel as though they were being evaluated fairly in terms of the decisions that they were making. We all know that physicians are high achievers, and, kind of being told that they're doing anything less than perfect can sometimes spur sort of this, but I did it right and you're kind of unfairly, judging me here. So we definitely wanted to avoid that in the original study. And that's how we kind of got to what we did, which was excluding those kids from those initial reports. What we found really interesting about feedback reports in general is that fundamentally, especially on a group level, it feels very much like a behavior change tool. That is to say, sort of reinforcing a recommendation that we had existing in a clinical guideline about the appropriate initial antibiotics and the appropriate antibiotic duration. So even though the kids with medical complexity were excluded from the reports themselves, the clinicians enacting the behavior and executing the application of the guideline were the recipients of the report. So it was very interesting to us, both to understand how that behavior change operated in the broader population of kids at our hospital, and also whether or not we did see any changes in children with medical complexity, again, because they are technically excluded from our guidelines.
Can you tell me a little bit more about why you chose the design of this study, how you determined it to be methodologically sound?
It's a great question. I think we tried to be careful in framing our conclusions that this was all done post hoc. We didn't a priori power this study, for example, to make a conclusion about the effectiveness, about the antibiotic choices people were getting. So I think that's an important thing to remember. So in some ways, we kind of were backed into the study design that we had because of the decisions that we made for the primary study, being a quasi-experimental study where we implemented an intervention and then did an analysis to understand what happened with adherence to the choice and duration metrics before and after that intervention, using essentially a time series analysis where we were able to look at both the trends in how clinicians were adhering to those metrics before the intervention, what change happened immediately as a result of the intervention, and what change happened over time following the intervention. And I think all all of that is really important because I think sometimes we fall into these more simple pre-post analyses where we're just like, okay, before it was like this, after it was like that, but it doesn't account for any sort of secular trends in how things may have changed over time. And additionally, doing it in the way that we did using a multivariable model allowed us to adjust for things like seasonality. As you said, we had two hospitals that were, a little bit different. One was a quaternary care center, one was more of a community center. And so we were able to adjust for some of those additional variables. So all that is to say that although we kind of inherited the study design for the current paper based on what we had done before, and we had the sample size that we did, we tried to, one, be transparent in our methods and use the most robust tools available to us. And then two, just being transparent about, the conclusions that we can make based on the analysis that we did.
Yeah, can you share a little bit to our listeners about what the key findings were?
Yes, absolutely. So essentially, what we did in this study was we identified a cohort of children who, as I said, were excluded from the primary study, but kids with medical complexity as defined by the Feutner CCC scheme. I imagine many listeners are already familiar with this scheme, but essentially it's a somewhat validated group of ICD-10 codes that identify kids at higher risk for healthcare resource utilization and mortality. And they're used for all sorts of things. And we chose to use them in this particular study because they're broadly available across many sites, and they were a very practical tool to use. At any rate, within that cohort of patients, we focused on those kids meeting those criteria who were cared for by the same set of general pediatricians who received the reports, but as I said, were excluded from the reports. During a 12-month baseline period, we looked at their adherence to appropriate antibiotic choice metrics, which for most kids was amoxicillin or ampicillin, and appropriate duration metrics, which for most kids was a 5-day duration of treatment for community-acquired pneumonia. And then we measured adherence to both of those metrics following the intervention using the methods that I described before, the time series design. And essentially what we found was that the intervention was associated with a statistical increase in appropriate antibiotic choice following the intervention, as well as, at least in the pre-post intervention, an increase in appropriate antibiotic duration. That just missed statistical significance in our model, but certainly there was an increase in the proportion that was inherent to that duration metric and an overall trend in adherence to that duration metric as well. We thought this was really interesting. I'll call it hypothesis generating results. As I mentioned, we can't broadly make an effectiveness claim about all children with medical complexity receiving this antibiotic choice and duration, but at least in the limits of our sample size and the analysis that we performed, there did not appear to be any signal for harm with following these, antibiotic stewardship recommended antibiotic choice and duration metrics in this population. And then certainly, as I've talked about already, there's some interesting things related to how feedback reports operate and change clinician behavior with regard to antibiotic choices.
And did you by chance find any trends within like subgroups of CMC that you studied, if certain groups were more or less likely to be adherent to antibiotic duration and choice?
Yeah, that's such a fantastic question. We had such a small sample size that it really precluded even subgroup analyses. So we did not have the opportunity to do that sophisticated of an analysis.
One of the things that you mentioned is that there is a complex care inpatient program at your hospital, but whether they're on the inpatient complex care program or a hospitalist, they would still be pulled into this analysis. And so that's great to know that it really wasn't like a narrowed subset, that it's really all children who met the CCC criteria. Just knowing your hospital system and the clinicians you work with, is there any other groups that might have not been seen that are children with medical complexity, but maybe like by diagnosis they had? If you see a lot of aspiration pneumonia, if you see a lot of other diagnoses that might exclude them from this?
Yeah, I think the one important thing to keep in mind is that we did exclude people who spent more than 2 days in the ICU, which sometimes that happens in this population because of any number of reasons, including severe pneumonia, but also for high burden nursing type needs. So I think that's the other important thing to keep in mind. That's not to say that we wouldn't have a similar conclusion if we had included those patients, but that group was excluded from this. And then severely immunocompromised people who were cared for generally by not general pediatricians, were not included here. And it's probably a cohort of patients that we wouldn't necessarily want these shorter durations necessarily to be applied to. And similarly, kids on mechanical ventilation in our institution, those kids are managed exclusively in the ICU, though some non-vented trach patients can be managed on the general floors. But kids with devices are probably another one just based on epidemiology where we wouldn't expect people to adhere to these choice and duration metrics. But short of those carve outs, I think that not necessarily based exclusively on the findings from this study, but just generally considering what places one at risk for having a more severe pneumonia, a harder time clearing your infection, risk of a drug resistant organism. I think there's really not so many carve outs beyond those. And so I think those are really things that are ripe for future consideration in other studies.
What can you share with researchers who are interested in doing this with their own work?
Yeah, I think it's a really important question because there's such a need to study this population, given that they're an increasing proportion of who's cared for in children's hospitals and where clinicians are really struggling, I think, to know if and when and how to, apply the findings from the trials that have largely excluded this population. So I think a couple of things. I think one thing is that we use the CCC scheme, which, as many know, is quite broad and heterogeneous in terms of who meets those criteria. And so I think one thing that could be done if we had a longer time, a bigger population, more centers, et cetera, would be to narrow it to a more heterogeneous cohort of children. It's never going to be perfect, but I think trying to define the study cohort as precisely as possible would be a really great methodologic improvement than what we were able to do with just this very small study. And then I think, including this population in trials, there's biologic reasons where some populations should be excluded. Severe immunocompromise, as I mentioned, severe lung disease, trachs, vents, those sorts of things. It makes sense to exclude them. But there's a lot of kids who are flagged by like the CCC schema and even some others that probably don't need to be excluded from pneumonia trials and probably would very much benefit from receiving the narrowest spectrum antibiotics for the shortest possible duration, avoiding the risk of antibiotic resistance, antibiotic side effects, et cetera. So I think when we try to be very clean with these trials and with observational studies, there's certainly a role for that. But I think we also do ourselves a bit of a disservice, and more importantly, this population a disservice by underappreciating that these things can be applied to them.
Yeah, I mean, you hit the nail on the head, and Katie designed such great studies, the predecessor and this follow-up study. And it's just so, just to reemphasize how important it is to make sure we know how to take care of all children, especially those who have medical complexity. And I think this is a really nice way to get to that next step, right? Because you might say, okay, we've treated the previously healthy kids. Now let's do a trial here. But using these observational data, like Katie was able to take advantage of, the trial was actually already starting to go on. And even though it's small numbers and wasn't particularly powered, it's going to give us and hopefully others some confidence that moving to these populations should be safe. And then I'll just make another, maybe more general comment that I think is relevant to this. Oftentimes, in medicine in general, but certainly antibiotic stewardship, less is more. And that does tend to cross a lot of different populations. We certainly the populations that Katie pointed out, if you're neutropenic and or critically ill, that's going to be a little bit different. But many kids who are diagnosed with community-acquired pneumonia probably have community-acquired pneumonia with the typical pathogens, and those are usually viruses, and if not pneumococcus, and pneumococcus can colonize anyone, regardless of your medical complexity. So I think thinking about these principles is important, and just making sure, again, circling back, that we do studies that treat all of our patients is so important, or study all of our patients, because if not, if we just keep leaving them out of the guideline, then we're doing experiments on them without collecting the data. What is the guideline? And so that can actually, in some ways, we feel like we're being safer and more conservative to quote unquote protect them, but actually it might be worse because we're not doing it in a very standardized way. So I think encouraging that type of research, whether it's observational or interventional, is just so important.
The article pointed out that 20% of your community-acquired pneumonia population is children with medical complexity. So it is a pretty big population to be excluding from standardized treatments and expecting that there won't be any consequences from that. Did you have any difficulty with maybe funders or your institution with studying this population?
Yeah, so the original study was the Centers for Disease Control and Prevention funded effort. So big shout out to the CDC. So we really appreciated the opportunity to do the original study with their support and collaboration. As we said before, this population was initially excluded, but it was actually the CDC who put some pressure on us as to why are you excluding so many people? How is this actually going to measure, performance overall at all of these hospitals when you're kicking out so many? And they understood the rationale that I gave to you, but I think it was in part because we kept coming back to this, but we're excluding so many. discussion that really motivated us to take a look at the broader population. In addition, I think the clinicians that we were working with, we would meet with them regularly to go over the feedback report, and they would say, that's great. They would have a lot of questions and a lot of engagement. But it came up many times also that there are other patients that we care for that are much more difficult. How should I approach the kid with severe congenital heart disease, or a kid who is on some non-invasive or some restrictive lung disease or what have you? And so I think that experience also really pushed us to want to do this. So I would say both from a funder perspective as well as from our own institution, there was a lot of interest in this, which was great.
Yeah, that's phenomenal.
Just to add to what Katie has said about CDC, when this study was funded a few years ago and have been terrific at funding this type of antimicrobial stewardship research, making sure we're addressing all populations. And we can't be grateful enough to them for doing that.
What do you think the implications are for clinical practice? What do you think you can tell pediatricians who are caring for kids with medical complexity with community-acquired pneumonias?
I think a couple things. One is that clinicians are able to, qualified to do, and should be empowered to apply the results of these national guidelines to their patients using the principles that we all embrace in terms of antibiotic stewardship, an understanding of the epidemiology of respiratory diseases in kids, and not to be overly conservative in terms of overtreating these patients. So I think building in that flexibility is really important. And then I think from like a stewardship perspective, which is not the direct care of these patients, but just really emphasizing that people who are in positions where they're at hospitals, where they're writing guidelines and giving clinicians the tools that they need to care for these patients, considering these additional populations that are so easy to leave out of guidelines because it makes it cleaner, is not actually helping the clinicians all that much. So to the extent that we can be more inclusive in the ways that we empower clinicians to make the right choices, I think it's incumbent upon us too to do that as we're writing these guidelines.
And if you could share any lessons learned or next steps from your research that you would like researchers or clinicians or even families to know about this.
I think from a researcher perspective, I mentioned this before, but I think just thinking about the study population and the methods that you're choosing for the study, being aware what you can and can't conclude, I think is really important. And with regard to this in particular, I would love to replicate this in a larger cohort, perhaps a more homogenous cohort, for example, kids with neurologic impairment. Because at least in my experience in the ICU, we're often very worried about aspiration pneumonia, about pseudomonas, and about things that probably epidemiologically aren't so important to deviate from these guidelines. So I think that would be a great opportunity and future direction from this work in particular. And then from a stewardship perspective, I think how we steward in light of uncertainty is really important, and how we give the tools that empowers clinicians to apply a little bit of individualized decision making and precision stewardship to the extent that we often can actually be a bit more flexible in our thinking and apply first line therapy to more kids than we might have otherwise thought, I think is a really interesting area of research that will take some kind of multidisciplinary approaches to understand qualitative methods, survey methods, user testing on feedback reports, and other sorts of things along those lines to understand the best way that we get the stewardship guidelines into practice with clinicians.
Yeah, I completely agree with all of that. And I think sometimes trying to find collaborators too, we have a lot of different electronic health records and it can be challenging. But if you have populations that might be slightly smaller, partnering with other hospitals, Children's Colorado and CHOP have both similar large academic centers with a lot of medically complex children. If you can throw in a couple more hospitals, you might then be powered to break into some of those subcategories and help. And maybe there is a difference, like Katie was saying before, between those with neurologic impairment versus those with gastroenterologic medical complexity. And Katie alluded to it, partnering with your PhD epidemiologists and biostatisticians and those who really can push the methods to use a lot of that pharmacoepidemiologic data to try to answer some of these questions even before a trial or to set up a trial is, I think, really important. And I guess one more thing I would mention is we like to think of lots of questions, and Katie has amazing questions. And sometimes I come up with questions that are worth answering. But talking to the frontline clinicians who might not be doing the studies and asking them, where's your uncertainty? And then sometimes talking to patients and families as well. So helping generate some of the ideas from the folks who you might be surprised and they say, we don't have a guideline for this, or what do I do with this patient? And you can really, I think that can be a meaningful next step in some cases.
Thank you for listening to the Complex Care Journal Club podcast. We aim to highlight research that has potential to be practice-changing, that values patient and family engagement, is relevant across all disciplines and diagnoses, and uses high-quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in the podcast using the form provided on the OPENPediatrics YouTube channel. Thank you for joining us.